Bueno, si nos vamos sentando, quería decirles que la foto la vamos a tomar al final, porque tenemos que correr las sillas para que entremos todos, así estamos todos en el grupo. ¿eh? Así que vamos a continuar ahora con COPD. Peter.
Thank you and welcome back. Now, this talk is on COPD, which is a much more difficult disease than asthma. So I stopped doing research on asthma about 20 years ago because I thought that inhaled steroids and LABA were the answer to asthma for most patients. But in COPD, we don't have good treatments, and there's a desperate need for more effective therapies. So there's a new definition of COPD now, which is not so reliant on spirometric abnormalities, but more emphasizing chronic respiratory symptoms due to structural changes that cause progressive airflow obstruction. So this is a more open definition, because some patients clearly have COPD, but they have normal spirometry. And we're not allowed to call them COPD previously, which means they don't get treated. But as you know, this disease is an enormous global burden affecting around 400 million people and affects around 10% of people over 45. Equally common in women, now that smoking prevalence is the same in women as men in Western countries, but in poorer countries, women are now smoking much more because of advertising by the tobacco companies. But COPD throughout the world is underdiagnosed. So GPs know very little about COPD in the UK, but they know a lot about asthma because there's been a lot of publicity about asthma, but much less publicity about COPD, which is the leading cause of acute admission to hospital in the UK and many other countries. And even though COPD is ranked as the third commonest cause of death in the world, many people have never heard of COPD. And you think that's because non-medical people don't know about any disease, but they do know about lots of diseases, but they don't know COPD. But even my colleagues at Imperial College, London, the second highest ranked university in the world, we work with people in chemistry and physics and do some studies on COPD, and they've never heard of COPD. I mean, these are top professors in the world, and they've never heard of this disease. So we have to do much more to inform the general public about the importance of this disease. And it's extremely expensive as a disease because it's such a common cause of hospital admission. And also the drug bill is very high. So it's going to get more and more expensive because the disease is actually increasing, despite the fact that smoking prevalence has gone down markedly in most countries. In the UK, 15% of people now smoke. It used to be about 30% a few years ago. But COPD is not going down because people are living longer. And those of you who went to my talk yesterday recognize that aging populations is the major challenge to internal medicine over the next few years. And COPD is one of these diseases that will increase as people's life expectancy increases. So we have major unmet therapeutic needs in COPD because there's not a single treatment that targets the underlying disease process. In marked contrast to asthma, where steroids, as we've just discussed, are highly effective in controlling T2 inflammation. But COPD is, I say largely, I think it's completely steroid resistant. And we know the mechanism because we've worked out the molecular pathways that make COPD unresponsive to steroids. So because we don't have a disease targeting a drug targeting the underlying disease, we can't reduce disease progression, and we can't reduce mortality, and we're not very good at stopping inflammation. Exacerbations, which are all the consequence of disease progression from chronic inflammation. So in GOLD, it's now finally recognized that there are different types of COPD dependent on the risk factors that are predominant. So a tiny proportion of COPD have a genetic cause. There are only two known genetic causes of COPD. One is alpha-1 antitrypsin disease deficiency, which is affecting less than 1% accounts for less than 1% of COPD. And the other one, which is even less common, is telomerase polymorphisms, which relate to accelerated aging. And yet, COPD is almost certainly genetically controlled because only about 20% of people who smoke will develop COPD. So the majority of patients of people that smoke will not and never will develop COPD. But abnormal lung development is now recognized to be an important factor. So particularly with premature births, when the lungs don't grow to maturity or they have delayed growth, and they never achieve normal lung function. And so they start from a lower baseline, and so the decline with age actually leads to symptoms because they're starting from a lower point. But cigarette exposure is the main risk factor in Western countries and is increasing in developing countries, as I mentioned. But we now recognize that air pollution is a very important risk factor for COPD. In India, more than 50% of COPD patients are never smokers, and they get COPD because usually they're exposed to biomass smoke because they burn wood and leaves and animal dung to cook their food. So this is household air pollution is very important. But it's now recognized from epidemiology studies that air pollution is very important as well, particularly particulate matter, which induces oxidative stress in the lung. And this is very important for us as specialists because previously the fact that cigarette smoking caused COPD meant that no research funding went to study COPD because this was thought to be the patient's fault. They brought the disease on themselves, which is the same reason there was no investment in research on lung cancer in the UK. But now we know that 20% of people with lung cancer have never smoked. And if you take 20% of lung cancer, that's far more common than leukemias, which receive enormous amount of research funding. So to give you one example from the UK, the Medical Research Council, which is the main funder of basic research in respiratory medicine, spent less money on COPD research than research onto hairy cell leukemia, which affected 4 people a year in the UK. And this is why we know so little about COPD, because there's been no investment in research. Infections are extremely common as a cause of COPD, and particularly tuberculosis. So in South Africa, the commonest cause of COPD is post-tuberculosis. And this is not because TB destroys the lung, but it causes some sort of fibrotic response in the rest of the lung that ends up looking exactly like COPD. But there's no research into the underlying mechanism. And we're currently trying to do some research with a group in Cape Town that has a lot of these patients that need to be studied. So post-TB COPD, which is sometimes called TOPD, is a very important mechanism in poor countries like India and South Africa. I've already discussed my position of COPD and asthma. These are two common diseases that occur together. It's not a spectrum of disease. And then you have some people who develop COPD with no obvious risk factors. But knowing that there are different causes has very little impact on the treatment that we use at the moment. So we did a study with some colleagues in India looking at a rural population. And COPD is quite common in Indian villages, particularly amongst women. And these women have never smoked because only men smoke in India. And what you can see is, in this study, we were comparing healthy people with COPD due to cigarette smoking and people with COPD who didn't smoke, mainly women exposed to biomass smoke from household exposure from cooking. So they had a similar severity of lung function. When we looked at we found very little difference between these patients in terms of the clinical measurements. But the non-smokers never had emphysema, whereas smokers did. And we think that's because the size of the particles from wood smoke are not reaching as far out in the lung as cigarette smoke. So smokers get emphysema and small airway disease, whereas the non-smoking COPD don't have they just have small airway disease. And we thought there might be a different pattern of inflammation, but what we found is that it's absolutely identical between the two patients. So they have the same number of neutrophils and eosinophils, and we couldn't discriminate. And what that tells us is that probably all COPD is the same mechanism, and it's the response of the respiratory tract to inhaled irritants, which could be cigarette smoke, but could also be particulates from indoor and outdoor air pollution. And there's a genetic predisposition in 20% of the population to respond to these irritants by getting airway obstruction. So I think everyone is trying to make COPD different, but I think it's actually the same disease in everyone, which nobody else agrees with. This is a slide I showed yesterday, and you know well that the patients with COPD are known as the susceptible smokers. It's about 20%, but as people live longer, the proportion of people that get COPD may increase. So when people are living to over 100, maybe most smokers might develop COPD. And the only intervention that can reduce progression at the moment is to stop smoking. This is the classical Fletcher-Peto diagram, which has subsequently been confirmed in other studies that were larger. But stopping smoking is something very important at every stage in the disease. But the longer they have the disease, the less the benefit of stopping smoking. So most benefit is in the people at the earliest stage of the disease. And at later stage of the disease, there's almost no benefit from stopping smoking. But there is benefit in stopping heart disease, even in severe patients. So patients with COPD, unlike patients with asthma, get progressively worse. So they go from gold 2 to gold 4. Most of them never reach gold 4. So this progression is something that we don't really see in asthma. Most people with mild asthma never get severe asthma. Most people with severe asthma start with severe asthma and never had mild asthma. It's a totally different disease process, but this one is progressive. So people are always going to need more treatment. And I think people don't appreciate how rare severe COPD is in the population. So if you look at a general practice population, and like asthma, COPD is a disease of general practice. You can see that half the people have moderate disease, which is gold 2, but only 20% have severe and very severe disease, and only 2% reach gold 4. And the reason why so few of them are there is that they've died of heart disease or lung cancer before they progress to very severe disease. And I think you need to bear that in mind. So we should put far more attention to dealing with milder disease than very severe disease. So there are various non-pharmacological treatments which are useful. The most important non-pharmacological intervention is physical activity, particularly if incorporated into a pulmonary rehabilitation program. And pulmonary rehabilitation is more effective than any drug therapy we currently have, and so should be used in as many patients as possible. The problem is that it's expensive because it involves time of people to administer it. So now people are looking at how you could administer it online. The trouble is that elderly people with COPD don't have computers and they don't understand online things, so it's a big problem. So a lot more people could be benefited by pulmonary rehabilitation and exercise training. So education is important, and then there are particular issues around end-of-life care, nutritional support, vaccination, and supplementary oxygen. So the first line of treatment is to reduce risk factors. So smoking cessation is extremely important for every patient with COPD. And nicotine replacement is widely used because people can go and buy nicotine patches and things at from the pharmacy. E-cigarettes are effective to reduce smoking, but my view is that these are very dangerous drugs, delivery systems that will lead to a new wave of COPD in the future. So we have to stop young people using e-cigarettes because it's been shown that this leads to, well, it causes nicotine addiction. That's the whole point. E-cigarettes are almost entirely owned by tobacco companies, and they use it as a gateway to smoking, which is exactly what happens. But actually, e-cigarettes may be dangerous in themselves because they contain many chemicals, and people are showing that if you take the e-cigarette liquid and you put it on airway epithelial cells, it's exactly the same response as with cigarette smoke. You get an inflammatory response, and you probably get senescence. We should study it. But this is going to be a new wave of COPD in the future, and governments must act to stop e-cigarettes being available to the public. In Australia, they've made e-cigarettes only available on prescription by doctors and only indicated for stopping smoking. And we should adopt that in every country. Our previous government wouldn't do that because the tobacco companies used to give them a lot of money. But we now have a new government which is doing the right thing. The other treatment that is the most effective treatment for quitting smoking is varenicline, which is a partial nicotine receptor agonist. And that stops the nicotine addiction. It's the most effective treatment. And it only needs to be given as a 6-week course. For non-smoking COPD, it's been shown that improving ventilation in the home reduces COPD, and using clean cooking stoves instead of burning leaves and animal dung is reducing COPD. So these interventions have been shown to be effective. And vaccination is very important. We know that influenza vaccine is effective in COPD patients in reducing exacerbations during influenza epidemics. COVID-19 vaccine is effective in COPD patients. And increasingly, people are now using pneumococcal vaccines. So in the UK, it's a routine vaccination for people over 60 to reduce pneumococcal pneumonia. So as you know, GOLD has been updated recently to simplify the management of COPD, just the same way that GINA has markedly simplified the management of asthma. So spirometry will confirm the diagnosis, but is the most value of spirometry is to grade the disease so you know what the severity is, because this tells you what the best treatment approach would be. But then you need to assess people for which would be the best treatment to start therapy. And this is done by finding out the exacerbation history and how much they're affected by symptoms, which can be done with the CAT questionnaire or the modified MRC score, which are very easy to administer in the clinic. So you classify people into these 3 groups. So well, I think you know all this, so I don't know why I'm saying it. But let me just point out something that you are never told when you go to the ERS and ATS, is that 70% of COPD patients never have an exacerbation. All the discussion of COPD at the ERS and ATS is about treating and preventing exacerbations, which are not going to happen in the majority of people. Now, if you look at the pathology of COPD, I think you can see why this is a very difficult disease to treat compared with asthma. So the main site of the disease is peripheral airways. I think now we regard emphysema as relatively unimportant and something that happens only late in the disease, which has little clinical impact. So the disease is really one of small airway narrowing. And you can see in this small airway from COPD that the airway is narrow, and you can see the wall is thicker than normal. That's because you have inflammation, but you also have fibrosis, which we just mentioned is progressive. And the other change is emphysema, which is occurring late, where you get destruction of the alveolar attachments to small airways. And this has very important physiological consequences. So when normal people breathe out, the airways never close because the alveolar attachments contain elastin fibers that keep the airways open even when you empty the lungs. But in COPD patients, the airways are narrowed and the alveolar attachments are disrupted. So when people breathe out, it completely closes the airway. And that traps air in the lung periphery. So this is what we describe physiologically as hyperinflation, which you can measure by plethysmography. So you see an increase in TLC and residual volume, but most importantly, an increase in FRC. So COPD patients have a higher resting lung volume, and that's uncomfortable, and it means they have less inspiratory capacity. So when they exercise, they get more air trapping. So this is known as dynamic hyperinflation. This is the key physiological defect of COPD and accounts for the symptoms, shortness of breath on exertion and reduced exercise tolerance, which are the major symptoms of COPD. But fortunately, we can reduce air trapping with bronchodilators, and what we know is that long-acting bronchodilators are much more effective than short-acting bronchodilators because they maintain the airway open. They work by relaxing small airways to reduce air trapping. And there are two types, well, you know all this, so you have LAMAs and LABAs, and they should be equally effective. But LAMAs seem to be more effective than LABAs. So here is tiotropium, and you can see there's an increase of FEV1, which is significant, but there's a much greater reduction in FRC, which is telling you that tiotropium is acting on small airways to reduce air trapping. Tiotropium was the first drug, the first inhaler that lasts once a day, and is a very effective bronchodilator. But we discovered an old drug called glycopyrrolate, which was used as a tablet by an anaesthetist to dry secretions in the mouth before anesthesia. And we were looking at the pharmacology of muscarinic receptors, and we decided to look at this glycopyrrolate, and we found it was pretty much identical to tiotropium. So we then gave it by nebulizer and found that it was having the same time course as tiotropium. So we went to the intellectual property people at Imperial and said we should patent this as a new inhaled treatment. And they said, no, there's no point patenting it because it's an old drug. And we said, but this is a new use. And they said, no, it's not worth spending the money. You might as well publish the study, which we did. And when we published it, a Japanese company saw the study and developed a dry powder formulation of glycopyrrolate, which they then sold to Novartis for $1 billion, which could have been ours. So I feel rather annoyed about glycopyrrolate, but it's a pretty good drug. And in fact, there are several LAMAs now available. So umeclidinium and revefenacin are once a day, whereas aclidinium has to be given twice a day. And all of these LAMAs produce a sustained increase in FEV1. They reduce air trapping, reduce symptoms, improve the quality of life, and reduce exacerbations. It was not expected that a bronchodilator would reduce exacerbations because people thought these were due to a flare-up of inflammation from infection. But they probably do it by stabilizing the airway so that when it's infected, it's not narrowing as much. So it doesn't count as an exacerbation. So anticholinergics, in contrast to asthma, are very effective bronchodilators. And the way they work is because normal airways have a certain degree of vagal tone, which means the cholinergic nerves are releasing acetylcholine continuously at the airways, and so you get a slight bronchoconstriction, which is the cholinergic tone. In COPD, you have the same amount of cholinergic tone, but it now has a much greater effect on airway resistance, because the airways have this fixed narrowing from scarring. And if you look at resistance, it's proportional to the inverse of the fourth power of the radius. So when you get further narrowing, it has a much greater effect on resistance than the same narrowing in normal airways. And similarly, if you block cholinergic tone, it has a very small effect in normal people, which is imperceptible. But in COPD is a big effect because of this geometric relationship between the airway caliber and resistance. So LAMAs specifically block cholinergic receptors, so they block cholinergic tone. LABAs block cholinergic tone because they're blocking any bronchoconstrictor mechanism. In asthma, bronchoconstriction can be caused by cholinergic tone, but mostly is caused by bronchoconstrictor mediators coming from mast cells, particularly leukotrienes and prostaglandin, which are causing bronchoconstriction. And all of these things are blocked by a LABA. So a LABA is always better as a bronchodilator in asthma than a LAMA. But in COPD, they seem to be similar. And what that means is that cholinergic tone is the only reversible mechanism in COPD. There seems to be nothing else. Otherwise, the LABA would be better than the LAMA. In fact, if you compare LABA and LAMA, LAMA tend to be better. So in this study, they compared a LAMA once a day, which is tiotropium, with salmeterol twice a day, which is the normal way to give salmeterol, which lasts about 12 hours. And you can see that there's a significant benefit of tiotropium in reducing exacerbations compared with salmeterol. And that's particularly seen in the people with severe exacerbations. So it seems that LAMA are somehow working better than LABA, which is not understood. We don't see why this is the case, but it may be because the LAMA is having some additional effect on mucus hypersecretion. As you know, we now have once daily beta agonists, the first of which is indacaterol. And indacaterol is a very effective bronchodilator in COPD, and it's more effective than salmeterol given twice a day in terms of improving symptoms, lung function, and the quality of life. And I think the bottom line is the longer acting the bronchodilator, the more effective it is in COPD. And that's probably because the bronchodilation carries over to the next day. And even if people miss a dose, it doesn't matter so much because the drug is long-acting. So the longer acting the drug, the better. Now, this is a quite extraordinary study that produced a totally unexpected result. So it's long been known that anticholinergics and beta agonists have additive bronchodilator effects, which you can see with salbutamol and ipratropium. But this study is unique because what it showed is that they gave indacaterol. 300 micrograms is the maximum dose that we ever use, because if you go higher, you get bad side effects that last 24 hours, so it's not advisable to increase the dose. But in this study, they doubled the dose, and of course they got a lot of side effects, but they didn't get any further effect. So what that's telling you is that the LABA is giving the maximum possible bronchodilation, because LABAs counteract every bronchoconstrictor effect there is. And yet, when they added glycopyrrolate, you can see a doubling of the bronchodilator response, which is going up to 300 mils, which is the sort of increase that we typically see in people with asthma and never see in people with COPD unless they have asthma. So this was a remarkable study, because we still don't understand the reason how you can get this doubling of benefit when you've got the maximum effect of the beta agonist. And we think the mechanism is related to interaction of two different signaling pathways that become synergistic. So this is a very important study, and even that was a short-term study just to look at doses, but even if you give this combination of LABA and LAMA, what you can see is that it's still giving this additive effect even after 6 months. So that's led to the development of LABA-LAMA fixed-dose combination inhalers, and these can be given once a day, so you have 3 choices. I think they're all pretty similar in terms of their efficacy. Or you can give twice daily, which give similar clinical benefit, but you need to take them twice a day. And all of those are using formoterol as the LABA. And these LABA-LAMA combinations reduce air trapping to a greater extent than LABA or LAMA alone, which reduces symptoms, improves the quality of life, better reduces exacerbations, but also improves cardiac function. And we know that these combinations are well tolerated. There are very few side effects that limit dose. So some drug companies looked into a new type of drug that combined a LABA and a LAMA in the same molecule. So they had a linker that linked a LABA and a LAMA. And these drugs, like batifenterol and navafenterol, were developed. But these turned out to be of no value. And the reason is that you can't balance the activity. So I think if you look at batifenterol, it's mainly a beta agonist, whereas navafenterol is mainly an anticholinergic. And once you've made the drug, you can't change it. Whereas in a combination, you can vary the proportion of drugs to get the optimal bronchodilator effect. So I think these MABAs have now been discontinued. So as you know, cardiovascular comorbidities are extremely common in COPD. 70% of COPD patients have cardiovascular disease, and we know that this can also be improved by long-acting bronchodilators. So in this study, they looked at a LABA-LAMA combination compared with placebo, and you can see that you get good reduction of air trapping, but at the same time you can improve cardiac function, because the air trapping inhibits cardiac output, and so by reducing air trapping, you actually improve cardiac function. And so this is an important benefit of long-acting bronchodilators. So back to the gold recommendations for initial therapy based on the ABE grouping. It's recommended that bronchodilators should be used in every patient. I should say that Gold A is hardly ever diagnosed in clinical practice because they don't have enough symptoms, but if they did, they would get a short-acting beta agonist probably. But there are a lot of people fit into Group B that never have exacerbations but have symptoms. And these patients are helped by a LABA/LAMA. And that should be the first choice. There's no point giving a LAMA and then a LABA later, because you might as well get the best effect from the beginning. And that's why this fixed combination is the first-line treatment for all patients with COPD. It's also true for Group E patients because both LABA and LAMA reduce exacerbations, and LABA/LAMA combinations reduce exacerbations more than the single drugs. But in the exacerbation group, you may also consider to add an inhaled steroid. And what we now recognize is that we can predict which patients will have a reduction of exacerbations with inhaled steroids. And they are patients that have increased blood eosinophils. In other words, they're the patients that also have asthma. So there's been a lot of controversy about the use of inhaled steroids in COPD. And I think things are now becoming clearer, but I've been in a lot of debates arguing against the use of inhaled steroids in COPD, whereas people sponsored heavily by drug companies argue that they're extremely valuable. And today, they're used in over 80% of COPD patients in the UK, which is a shocking misuse of therapy. The only thing that inhaled steroids do to benefit COPD patients is to reduce exacerbations. They have no effect on symptoms, disease progression, mortality, or comorbidities. And this is a meta-analysis of studies comparing high-dose inhaled steroid versus placebo in exacerbations. And you can see that there's a significant reduction of exacerbations, although it's quite small. It's a 20% reduction, so not a very big effect, but nevertheless consistently found in studies. And yet you don't see improvement of FEV1 in symptoms or quality of life, no effect on mortality, either respiratory death or cardiovascular or cancer death, no effect on FEV1 decline, so it's not reducing disease progression. So this is a study from my colleague Vishwa Zitsche, who looked at reducing exacerbations in COPD with ICS-LABA, which was fluticasone salmeterol, versus LABA/LAMA, indacaterol glycopyrrolate. And you can see that the bronchodilators were more effective in reducing exacerbations. And this was irrespective of the sex, race, smoking status, severity of disease, or whether people had previously used inhaled steroids. And what we now recognize is that there's a subpopulation of COPD patients that benefit from inhaled steroids. And this relates to the blood eosinophil count, which, as you know, is a biomarker of asthmatic inflammation. This is a post hoc analysis of studies that compared ICS-LABA against the LABA alone. And you can see that with exacerbations, the LABA/LAMA is not different at low blood eosinophils, but once you get above 300, you then see a significant difference between the LABA/LAMA and the LABA alone. So in other words, the steroid is reducing exacerbations once the eosinophils go above 300. But in fact, most people are given high-dose inhaled steroids. Paradoxically, they're given high-dose inhaled steroids because the steroids don't work, so they give the highest dose. So they have the greatest risk of side effects of any people given inhaled steroids. And that's because many of these patients are elderly and more susceptible to steroid side effects. So you get local effects, which are not such a problem, but dysphonia is quite common. So people get a hoarse voice, but old people don't speak much, so they don't complain too much about this. So you see it in lecturers complain and opera singers, but normal people that have COPD don't bother with it. But the big problem is the systemic side effects, because you're giving high doses and the steroid is absorbed from the lungs and can cause fractures. So we know that using high-dose inhaled steroids in the population increases the risk of fractures. And already COPD patients have an increased risk of fractures because old age, low mobility, poor nutrition, and smoking are independent risk factors for osteoporosis. They also have a risk of cataracts from the steroids. Comorbidities like type 2 diabetes and hypertension are made worse by steroids. And the thing that people have really been concerned about is the increased risk of lung infection, pneumonia, TB, and non-tuberculous mycobacterial disease. In fact, there's an enormous increase of risk of NTM in COPD patients on inhaled steroids, something like a 20-fold increased risk. So you shouldn't give inhaled steroids unless the patient is clearly going to benefit. So giving this drug to 80% of the population is bad medicine. The risk of pneumonia has attracted the most attention. So if you look at this large TORCH study, which was conducted over 3 years, was the first study to identify that you got an increased risk of pneumonia with inhaled steroids. And that was only possible because they did the study for 3 years rather than 1 year, because this is a cumulative risk that you may not see at 1 year. But by 3 years, you can clearly see that salmeterol fluticasone and fluticasone alone are significantly increasing the risk of pneumonia. So the number needed to treat to prevent one exacerbation, which is the only clinical reason to prescribe an inhaled steroid, is 44, but the number that needed to give a pneumonia is only 16. So this is a very bad risk-benefit result. I mean, in general, inhaled steroids are detrimental. And this is confirmed in community epidemiology studies. So in this Canadian study, they looked at COPD patients in the population who were on inhaled steroids. And you can see there's a marked increased risk of pneumonia. And the steroids differ from each other. So the worst steroid is fluticasone, either fluticasone propionate or furoate. This has a much greater risk of pneumonia, and we know the reason for that is the fluticasone is retained in the lung and allows bacteria to proliferate in the lung of COPD patients. So no patient with COPD should ever be given fluticasone as an inhaled steroid. By contrast, budesonide has a very low risk of inhaled steroids because it's not retained in the lung in the same way. And here you can see that blood eosinophils can also be helpful to predict the risk of pneumonia with inhaled steroids. So what you have here is the inhaled steroid patients getting more pneumonia. But if you look at the top two lines, you can see that the ones with eosinophils less than 2%, which is like less than 150, have a greater risk of pneumonia. So eosinophils are very useful because the ones that have high eosinophils not only respond to steroids, but they're less likely to get pneumonia. And giving inhaled steroids to these other people is just bad medicine. It has a risk of making them worse. So it's like a 50% increased risk of pneumonia if you have low eosinophils. So what we have to do is take inhaled steroids away from almost every patient with COPD. And we know that this can be safely done. So this was the first big study that looked at the controlled withdrawal of inhaled steroids, the Wisdom trial. I'm sure you're familiar with it. But they took people that were on triple inhaled therapy that had exacerbations, and they withdrew steroids over 12 weeks. They didn't suddenly stop them because otherwise they get steroid withdrawal symptoms. So you can see that they didn't get a flare-up of exacerbations when the steroids were stopped, so it was safe to do it. And then if they looked at the people who had only one exacerbation in the year before, you can see that even if they had high eosinophils, you could stop the inhaled steroid. If they had 2 or more exacerbations in the previous year, so gold E, then if they had high blood eosinophils, then they did get more exacerbations. So again, we can use the blood eosinophil count to predict which patients can be withdrawn from inhaled steroids. This is another study that was a prospective study. The other study, the Wisdom study, was a retrospective study. So here you are de-escalating, so from triple therapy to LABA/LAMA bronchodilators. So in other words, you're withdrawing the steroid. And you can see that the people that have less than 300 eosinophils, which is the majority, so 76% had low eosinophils. There was no effect of stopping the steroid, but there was an effect if they had over 300, and that was about 24% of patients. So adding inhaled steroids to bronchodilators should be done if there's a history of hospitalization or exacerbation, if they have 2 or moderate exacerbations a year, but only if their blood eosinophils are increased, or they have known asthma, which I think actually accounts for all of them. But we should never use inhaled steroids in people with a history of pneumonia, in people with low blood eosinophils, or a history of tuberculosis, because we know that inhaled steroids can reactivate TB. And then there's a middle group who have just 1 exacerbation in the previous year. So they're not fully E or B, they're between. And these are not uncommon. So we say that it could be a useful treatment in these people between 100 and 300. So which COPD patient should get COPD? They should be the frequent exacerbators despite LABA and LAMA, with 2 or more severe exacerbations or 1 hospitalization, which are now called Gold E, with blood eosinophils of 300 or more per microliter, or more than 4%, which sometimes expressed that way. People with asthma COPD overlap because asthma and COPD coexist, and people with no contraindications to the side effects of steroids, so pneumonia, diabetes, osteoporosis, previous TB. And this is currently thought to be around 10 to 20% of COPD patients, whereas, as I was saying before, more than 80% are now treated with high-dose inhaled steroids from the beginning with triple inhalers. But if a patient can benefit from inhaled steroids, which is basically treating the coexistent asthma, then you have a choice of different fixed-dose triple combination inhalers. And these have been shown to be effective in COPD. So this is a triple combination inhaler that has vilanterol, umeclidinium, and fluticasone furoate. And what you can see is that the triple gives a significant reduction in exacerbation compared with the LABA-LAMA and the ICS-LABA. But this study needs to be interpreted very carefully. The difference is very likely a misleading improvement, because most of the people were on inhaled steroids when they entered the trial. So when they were switched to bronchodilator alone, what happened is that it's like taking the steroid away, and they got sudden steroid withdrawal. So they felt very tired, and that was counted as an exacerbation because they felt worse. So they ticked the boxes that they were worse. And it only happened during the first month of the study when the steroid withdrawal Addisonian symptoms are occurring. So there may not be a big difference for this general population. Furthermore, pneumonia was increased by 50% in the ones on inhaled steroids. But that's because fluticasone was used as the steroid. This is not seen when budesonide is used to nearly the same extent. So follow-up treatment, if the patient, despite having LABA-LAMA, is still having symptoms, you have to consider switching the inhaler device, because maybe they're not getting the drugs into the peripheral lung. So this is something very important in COPD. The disease is in the small airways, not the large airways, like asthma. So the inhalers may not be so efficient to reach peripheral airways, especially when they're constricted because of the change of airflow pattern. So you then have to look at non-pharmacological approaches as well to improve them. And then you look at other causes that may be causing them to be short of breath. Many COPD patients develop heart failure, which is a comorbidity linked to accelerated aging, for example. So that's what we do for if they continue to get short of breath. But if they continue to have exacerbations, then we look at the blood eosinophil count, and if it's increased, we then consider to add ICS as a triple inhaler. In the gold recommendations now, ICS LABA are never to be used in COPD patients because there's no rationale. If you need a steroid, it's always going to be on top of LABA-LAMA. So it's much better to give a triple than to give, well, because they're already on dual bronchodilator, so there's no sense to ever use ICS LABA. So that's an important message. So triple inhalers are very useful for this specific group because they treat their asthma. And then you have two further treatments which can be used in some patients. I'm not sure if I have slides of these. I think I didn't have slides of the other one. Let me go back. So roflumilast is a phosphodiesterase 4 inhibitor. I suppose you have it here. This is completely useless as a treatment because not a single patient can tolerate more than one dose. It's a dreadful drug that has trivial effects, and unlike most drugs that are approved, it actually worsens the quality of life in COPD patients because they get headache, diarrhea, nausea and vomiting, and hardly any clinical benefit. So we've completely stopped using roflumilast. Even in the USA, where they give every treatment there is that's expensive, they've stopped using it. So I think we can cross out roflumilast, but azithromycin is a useful treatment in some patients because it does reduce exacerbations in people with severe COPD, and it seems to work better in ex-smokers and people that have chronic bronchitis. We don't know how it's working. It's probably not working as an antibiotic, but as an anti-inflammatory treatment against neutrophilic inflammation. So we don't use it very much because there are long-term adverse effects, the most serious of which is the development of antibiotic resistance, which makes the treatment of pneumonia and exacerbations more difficult in the future. It can cause diarrhea. In elderly people, it can cause deafness, and large studies show that it causes cardiac arrhythmias in elderly people. And as you know, these COPD patients are at risk of arrhythmias because they have cardiovascular disease. So it's not a treatment that we should consider in every patient, but a few patients. I think the ones that we would use azithromycin is when they have a lot of purulent sputum, because bronchiectasis is quite a common comorbidity in severe COPD. So COPD is a major health burden that is increasing, and it's very poorly treated in general practice and throughout the world. Half the cases of COPD are not even diagnosed, so they don't even have a chance of having treatment. But the treatment of choice is long-acting bronchodilators that work better in combination. And we know that that reduces symptoms, improves the quality of life, reduces exacerbation, and improves cardiac function. Inhaled steroids reduce exacerbations, but have no effect on symptoms, mortality, or progression. They're only really useful if the blood eosinophils are more than 300, or maybe some effect above 150. So overall, we estimate that 10 to 20% of COPD patients can benefit from inhaled steroids rather than the vast majority that currently receive them. Withdrawing inhaled steroids is safe if the blood eosinophil count is below 300 and patients have infrequent exacerbations. I didn't have time to talk about new treatments, but maybe in the discussion we can discuss this. But there are several new anti-inflammatory therapies in development, and only last week, dupilumab was, I think I mentioned that in the last discussion, was approved in COPD for eosinophilic COPD, which is actually asthma that they have. So it works on the severe asthma that they also have. And the reason why asthma is really bad in COPD, if you have the diseases together, is that the oxidative stress of COPD stops the molecular mechanism for steroids to switch off inflammation. And that's why asthma becomes much more troublesome in those people, because steroids are not working anymore. And that's why probably dupilumab can work. But people are looking at other biologics, JAK inhibitors and IRAK4 inhibitors, for example. And then yesterday in the lecture at the Academy, I talked about xenotherapies, which I think are the long-term future for COPD and other chronic diseases. So I'll stop there and happy to discuss these issues.
Thank you very much. I would like to ask if you have questions to Professor Barnes. Yes, Alejandro?
What do you think about the two large studies published in the GOAL guideline about impact and ethos, about to reduce mortality in COPD patients?
I think that's a good question. I did actually have a slide, but I wanted to keep the talk shorter so we could have more discussion. But I think this is a real observation, because it's been found with both triple inhalers that were looked at. And it seems that the reduction of mortality, the problem is the study was not powered to measure mortality. So there are very few deaths, because these are only for 1 year. This is not a long study like TORCH. And they both show similar results, so it's probably correct that mortality was reduced. I think it's not statistically significant, but it's clearly a trend. And all of the deaths that were reduced were from cardiovascular disease. It's a marked reduction of cardiovascular mortality. Now, one thing that we've been looking at is the effect of steroids on senescence of endothelial cells. And we now have a big study that we're doing with AstraZeneca to look at where the triple inhaler, or at least the steroid in the triple inhaler, is reducing senescence in endothelial cells, because the steroid reaches the circulation, compared with the dual bronchodilator. And it could be that there's a benefit in mortality, in which case then you would say triple inhalers should be used for the COPD patients that also have cardiovascular risk. And that could be future. But before we could recommend that, I think we can't take post hoc analysis of these smallish studies. You have to do a prospective large study. In other words, you have to repeat the TORCH study, but with triple inhalers. And I think this is what they plan to do now, because it's an important discovery that you could reduce cardiovascular mortality, because that's the commonest cause of death in COPD. So I think it's a real effect, but we don't understand the mechanism.
Thank you for the wonderful talk. But taking into account the high risk of mortality events in COPD patients, do you think COPD is the respiratory phenotype of our cardiovascular disease? Because both diseases are very common, and the more the COPD patients, the most common cause of death is cardiovascular, not respiratory failure. So it's kind of COPD is kind of a respiratory phenotype of cardiovascular disease. Do you agree with that view, or?
Well, no. As I described in the lecture yesterday, we think cardiovascular disease and COPD is a manifestation of accelerated aging. So they share a mechanism. So, and also the disease is spread. So if you have COPD, you can spread senescence to the circulation. But it may also be that if you have cardiovascular disease, you could have more COPD, because the vesicles could come from the blood vessels and go to the lung. But we don't know that. So I think they're just common comorbidities of each other. So if you look in a cardiac clinic, you will find a lot of people with COPD that were never diagnosed because cardiologists never measure spirometry. What they do is send patients that they've treated that don't respond to heart failure. They send it to respiratory specialists and say, short of breath, can you find not cardiac, can you find the cause? So they're like GPs, they don't measure FEV1. But actually FEV1 is one of the best predictors of cardiovascular mortality that there is. So there's a close link between cardiovascular disease and COPD. And it's the common cause of death because I think they have this common pathway.
Thank you. Another question? Yes?
Hola. Thank you for your nice talk. Well, in Argentina, annually, the last 4 years, the laboratory sell the wholesale of the inhaled devices are 8 million of devices per year. 80% are salbutamol, SABA, and EIA's LABA. So what we can do about that?
Well, I mean, we've got to educate people, and we have to get across the idea that long-acting bronchodilators are the best treatment for patients, and they will be cost-effective because they reduce hospital admissions, they reduce time off work, quality of life, and you save money by giving more effective treatment. To give salbutamol will never improve them as much. I don't think there's a single study showing that salbutamol reduces exacerbations, because the mechanism for reducing exacerbations, as I mentioned before, is to stabilize the airway so that when they get some infection, the airways are not narrowing because they're fully dilated from the long-acting bronchodilator. And that's why you reduce exacerbations, because people always thought that to reduce exacerbations, you had to have an anti-inflammatory drug because inflammation increases during COPD exacerbations. And that was the rationale for using steroids as an anti-inflammatory. But of course, the inflammation of COPD is completely steroid resistant. It just does not respond to steroids because it's a different pattern of inflammation to COPD. So I think, people tend to use the cheapest treatment. So it's down to the government and to us to educate people and the government about the importance of giving long-acting bronchodilators for COPD. So this should be the first-line treatment for every patient with a diagnosis of COPD, whatever the severity.
Are there any role for statins or beta blockers in the COPD treatment? No cardiovascular, the COPD treatment.
There was. There was a rationale for. People were very worried about giving beta blockers to COPD because it makes asthma worse. And we used to do a lot of research on beta blocker-induced asthma. We worked out the mechanism, which is due to beta receptors on mast cells. If you block them with a beta blocker, the mast cells increase bronchoconstrictor release. And so we thought that's the mechanism for working. But in COPD, mast cells are not involved in the disease, as you can see by the fact that beta agonists don't work very well. And so I think that this is a rationale to use them for cardiac failure because beta blockers are quite useful intervention. And there are studies showing that they're safe to use in COPD in controlled trials. The problem is that if you recommend beta blockers in the community, GPs are going to give them to COPD patients, but they may have asthma, and the GP has misdiagnosed them. So probably we shouldn't give beta blockers because there are a lot of alternative treatments for heart failure and arrhythmias. But I think they're safe if they have pure COPD. But there was a study that actually looked at beta blockers, and they found it didn't reduce exacerbations. So it wasn't beneficial, but it wasn't harmful. But it's harmful if GPs give it inappropriately. That's my position on it. So don't use them. What?
Statins? Statins?
Statins. Well, the study that was done with statins didn't show any benefit when it was added to other treatment, triple therapy based. It didn't reduce exacerbations, but the study design was very poor, and they used really severe patients on a lot of them were on oxygen. So I think the study needs to be repeated in the sort of patients people normally see. I mean, oxygen is required by only a tiny, tiny percentage of COPD patients. They're the ones that come to hospital clinics. I mean, there's a very low need for domiciliary oxygen because unless you have clear nocturnal hypoxia, there's no benefit. There's no point just having a bit of oxygen when you're breathless. That's been shown to be completely ineffective. And it's also, at least in the UK, is extremely expensive as a treatment. It's more expensive than biologics. So we only use it for a very restricted group of people who are basically in respiratory failure. So it should never be initiated by a GP because these patients have to be carefully assessed by specialists. And it's a very small percentage. It's about 1% of the COPD population. It's a trivial number of people.
Okay. Another question? If there are no more questions, what we are going to have now is the picture, the photo.